Assalamu alaikum. Today I am going to discuss about the nephrotic and nephritic syndrome, the high thing coming in the exam in regarding to renal pathology. Okay, in nephrotic syndrome there is hypoalbuminemia, there is hypogammaglobulinemia. Hypoalbuminemia leads to pitting edema, hypogammaglobulinemia due to hypogammaglobulinemia causing increased risk of infection, and hypercoagulable state due to antithrombin 3 deficiency, and hyperlipidemia and hypercholesterolemia. These are the uh, features of nephrotic syndrome. And if we think about nephrotic syndrome, the first disease comes to our mind is minimal change disease, which usually occur in children. This is a picture of the minimal change. This is the electron microscopy picture of minimal change. This is EM picture of minimal change disease. And in every disease, we will discuss about the cause and the three finding: light microscopic finding, immunofluorescence finding, and electron microscopic finding. If we think about minimal change disease, it is mostly idiopathic, and it may be triggered by recent infection, immunization, immune status, immune stimulus, and mostly and mostly our secondary cause of this is lymphoma. This minimal change disease is associated with lymphoma. On light microscopy, you may get glomeruli. Normal glomeruli. Normal glomeruli is found in minimal change disease. In minimal change disease, there is normal glomeruli on H&E stain. Okay, immunofluorescence is negative, and electron microscope. In electron microscope, there is effacement of podocyte of the food process. Effacement of food process. Can we say it? Can we remember it again? In light microscopic finding, you may get normal glomeruli on H&E stain. Immunofluorescence is negative, and there is effacement of food process. Effacement of food process. Why there is effacement? Due to cytokine. In here there is a cytokine mediated damage, and as a treatment, corticosteroid, it responses great in if you give corticosteroid to these babies. And minimal change disease, also known as lipoid nephrosis. The next one, this is the picture. This is the light microscopy picture of focal segmental glomerulosclerosis. In FSG, in focal segmental glomerulosclerosis, the most common cause are HIV, heroin, and sickle cell disease. HIV, heroin, and sickle cell disease. Can we say together that HIV, sickle cell disease, and heroin abuse? And there may be other causes too, like mass obesity, interferon treatment, and congenital malformation. Massive obesity, interferon treatment, and congenital malformation. It doesn't respond well to the steroid, and it may lead to CKD. And on light microscopy, there is segmental sclerosis and hyalinosis. As the name says, that focal segmental glomerulosclerosis, there is segmental sclerosis and hyalinosis. There is segmental sclerosis and hyalinosis. There is segmental sclerosis and hyalinosis. Immunofluorescence is negative, maybe positive for non-specific focal deposits, will be positive for non-specific focal deposits. And in electron microscope there is effacement of podocyte of food process. Effacement of food process. So the difference between minimal changes and FHG in minimal changes is steroid works better, and in focal segmental sclerosis steroid doesn't work better. And minimal changes usually occur in children, and this FSG, focal segmental glomerulosclerosis, usually occurs in mm, adult and in Hispanic and African American. Hispanic and African American. Then the next one, this is the picture of membranous nephropathy. In membranous nephropathy, also known as membranous glomerulonephritis, it is usually most commonly occurs in Caucasian adult associated with hepatitis B, C, solid tumor SLE, hepatitis B, C, solid tumor SLE drugs, NSAID and penicillin. Can we remember it again? That in here there is hepatitis B, C, syphilis, and hepatitis B, C, syphilis, SLE, solid tumor. And in regarding to drugs, there may be NSAID and penicillin, and other thing, antibodies to phospholipase A2 receptor, antibodies to phospholipase A2 receptor, antibodies to phospholipase A2 receptor. On light microscopy, as membranous, there is thick glomerular basement membrane. There is thick glomerular basement membrane. There is thick glomerular basement membrane and diffuse capillary. And immunofluorescence is granular. Immunofluorescence is granular. On electron microscopy, there is spike and dome appearance of subepithelial deposit. Spike and dome appearance of subepithelial deposit. Okay, next one. This is the picture of diabetic glomerular nephropathy. This is the picture of diabetic glomerular nephropathy. In here there is nodular lesion. This is the nodule. This is the nodular lesion. Most common cause of ESRD in US is diabetic glomerular nephropathy. What happens in here? There is hyperglycemia, so there is non-enzymatic glycation of the tissue proteins and mesangial expansion, glomerular thickening and increasing permeability. So there is hyperfiltration and glomerular hypertrophy and glomerular scarring, leading to further progression to nephropathy. And on light microscopy there is mesangial expansion. On light microscopy there is mesangial expansion. On immunofluorescence on light microscopy there is mesangial expansion, and immunofluorescence is normal. Immunofluorescence is negative. And on electron microscopy, this is mostly diagnosed by mesangial expansion, glomerular basement membrane thickening, glomerular basement membrane thickening, and there is formation of a nodule called Wilson nodule. The most features in case of diabetic glomerulopathy is light microscopy glomerular mesangial expansion, glomerular basement membrane thickening, and formation of that nodule. STIL Kingston Wilson nodule. This is found on light microscope, and this is the important IL feature we found in nephrotic syndrome, mostly diabetic glomerulonephropathy, and there are other type of nephrotic syndrome called amyloidosis, and we know that in amyloidosis we get congruent stain shows apple green bright fringes under polarized light due to amyloid deposition on the mesenterium, and that's all about nephrotic syndrome. Now, in nephritic syndrome, first of all, PSGN, that means post-streptococcal glomerulonephritis. In PSGN, glomeruli is enlarged, glomeruli is enlarged and hypercellular. This is the enlarged and hypercellular glomeruli, and it immunofluorescence, it looks like stereosky appearance. It looks like stereosky. This is the stereosky. This is the immunofluorescence picture of PSGN, where you get this stereosky granular appearance, lumpy bumpy due to IgG, IgM, or I and C3 deposition on the GBM and mesenterium, and electron microscopy. There is subepithelial IC humps. There is subepithelial IC immune complex hump. So in PSGN, glomeruli is enlarged and hypercellular. There is on immunofluorescence, there is stereosky appearance, and electron microscopy, there is subepithelial immune complex hump. Then the next one, RPGN, that rapidly progressive glomerulonephritis. In RPGN, what happens in here, there is RPGN has to divided into three types. It may be linear, and linear immunofluorescence found in good pasture syndrome. In good pasture syndrome, there is antibody against the GBM. There may be POSI immunofluorescence. Linear immunofluorescence in good pasture syndrome. POSI immunofluorescence is microscopic. Polyangiitis, Shack-Strass syndrome, and Wagner granulomatosis. And the granular immunofluorescence is PSGN or DPGN. Can we remember it again? Yes. In RPGN, RPGN, on the basis of immunofluorescence, it can be subdivided into three types. In linear immunofluorescence, there is antibody against the glomerular basement remnant. On the other hand, in POSI immunofluorescence, there is microscopic polyangiitis. There is Shack-Strass syndrome in microscopic polyangiitis. There is MP-ANCA or P-ANCA positive. In Shack-Strass, there is C-ANCA positive, and GP granulomatous polyangiitis. PR3 ANCA, C-ANCA is positive. On the other hand, in granular immunofluorescence, there is PSGN or DPGN. Okay. This is the picture of DPGN. DP is proliferative glomerulonephritis. In here, on light microscopy, there is wire looping of capillaries. Immunofluorescence is granular. And on electron microscope, there is subendothelial and intramembranous IgE based immunocomplex. Subendothelial subendothelial and intramembranous IgG-based IC and C3 deposition. Can you remember why there is subepithelial deposit? Yes, in membranous nephropathy there is spike and bone nephropathy where there is subepithelial deposit or subepithelial humps. On the other hand, in DPGM there is wire looping. Immunofluorescence is granular, wire looping immunofluorescence is granular, and on electron microscope there is subendothelial and sometimes intramembranous IgG based immunocomplex. Okay, this is the picture of lupus nephritis. This is a picture of lupus nephritis. And last but not the least, that this is the picture of this is the picture of membranoproliferative glomerulonephritis. In membranoproliferative glomerulonephritis, what happens in membranoproliferative glomerulonephritis? In membranoproliferative glomerulonephritis, it can be divided into type 1 and type 2. Type 1 is subendothelial, and which is associated with HBV and HCV, and type 2 is associated with C3 nephritic syndrome. Type 1 is associated with subendothelial, which is associated with HBV and HCG, and type 2 deposit is intramembranous. And intramembranous there is thick glomerular. On light microscope there is thick glomerular basement membrane, and there is tram track appearance, thick glomerular basement membrane, and there is tram track appearance, thick glomerular basement membrane and tram track appearance presence in MPGN, tram track appearance present in MPGN, and the immunofluorescence is granular, and the last disease I will discuss about Alport syndrome. Alport syndrome is can't be, that means urethritis, can't see. You can remember this by this namely can't see, can't be, can't hear a B. Can't see, that means retinitis pigmentosa, retinopathy, lens dislocation. Can't be is glomerulonephritis, and can't hear a B is sensory neural hearing loss. So can't see, can't be, can't hear a B. That means can't see, that means lens dislocation, or retinitis pigmentosa. Can't be, that means glomerulonephritis, and can't hear a B. And on electron microscopy there is basket wave appearance, and this is all about this nephrotic syndrome and nephritic syndrome. Inshallah you will be benefited.